Hi, my name's Nigel Barraclough. I'm a registered paramedic, an experienced first aid trainer and the author of the UK's #1 range of first aid training books. As a trusted provider of training materials for over 8 million people throughout the UK, here at qualsafe.com we're committed to ensuring that our books contain up-to-date evidence-based guidelines presented in a way that's easy to learn so that first aiders are equipped with the exact knowledge that they need to save lives. That's why I'm delighted to announce that our range of First Aid Made Easy books have undergone a complete refresh, with updated first aid guidelines, new topics, simplified layouts and enhanced images. This video is designed for first aid trainers. It gives you a complete overview of the updates to make your life easy when you implement them in the classroom. So let's have a look at what's changed. Firstly, we're pleased to welcome one of the co-founders of Citizen Aid and a renowned expert in pre-hospital care to our clinical review panel. Professor Sir Keith Porter has a wealth of experience as a professor of clinical traumatology and is a key addition to our distinguished panel of experts. In addition to the expertise of Sir Keith, the clinical review panel, which reviews and supports our guidelines, includes HCPC registered paramedics, a consultant paediatrician and 3 consultants in emergency medicine, one of whom, Dr. Andy Lockie, is Vice President of the Resuscitation Council UK. Not only are we delighted to welcome Professor Sir Keith Porter to the clinical review panel, we're delighted to now be able to include a spinal recovery position that he co-developed and published with colleagues at the University Hospitals Birmingham NHS Trust. So why is this required? Well, let's look at the circumstances in which the spinal recovery position is needed. There's an unconscious casualty lying on their back with a suspected spinal injury. The first aider has supported the head with her hands using manual inline stabilisation to protect the spine. Then they become concerned about the airway. Perhaps the casualty has vomited or they're making gurgling noises when they breathe. Obviously, the first aider needs to turn the casualty onto their side urgently to clear fluids from the airway. Well, until now, the only specific methods for turning a casualty with a suspected spinal injury published in UK first aid guidance have required 1, 2 or sometimes 3 helpers. The first aider was expected to continue holding the head whilst recruiting bystanders to help, verbally instructing them where to kneel, verbally trying to instruct them where to put their hands, instructing them how to turn the casualty and then hoping that they could follow these instructions on their count so that the spine could be kept in alignment as the casualty was turned. We've known for many years that first aid guidelines need to be as simple as possible to give the first aider the best chance of helping in panicky emergency situations, and this revised spinal recovery position does exactly that. It enables a solo first aider to quickly turn a casualty onto their side, protecting the airway whilst minimising movement of the spine. Let's take a closer look at how to place a casualty in the new spinal recovery position. Firstly, the first aider needs to move to the side of the casualty, even though this means letting go of the head. Kneel at the side of the casualty and cross their legs, bringing the far leg towards you. Carefully slide the casualty's nearest hand under their head, palm upwards. Do this with minimal movement of the head. As a first aid trainer, this is probably the most important thing you need to focus on when you teach. It is acceptable with spinal injuries to carefully manoeuvre a casualty's head into a neutral position. And in fact, when lying on a flat surface, the spine is in the optimal neutral position when the back of the head is raised by about 2 centimetres from the floor. Of course, it's vital not to lift the casualty's head too much, which is why the guidance says to slide the hand under the head and to do this with minimal movement of the head. The best way to teach this in the classroom is for the first aider to place the casualty's nearest hand above their head, palm upwards. Without moving the head, the first aider carefully places their spare hand under the arch of the casualty's neck. Support the head with that hand and then slide the casualty's hand under their head from above until the back of the head rests in the palm of the hand. Next, bring the casualty's other arm towards you across their chest and then grasp the far shoulder and the hip simultaneously. Now, pull equally on the shoulder and the hip to roll the casualty towards you onto their side. Pulling equally at the shoulder and the hip is better than pulling on the knee because it places less twisting forces on the spine. Next, adjust the upper leg so the hip and the knee are at right angles. Note now that the guidance says to continually monitor breathing until emergency help arrives. As you can see, this is a massive improvement. It helps simplify the procedure and, most importantly, makes it much easier for a first aider to get it right in an emergency. Not only have we updated our spinal recovery position, but we've also improved the technique of how to turn a casualty into the standard recovery position. Whilst the recovery position itself remains exactly the same, the order of manoeuvres has been enhanced to improve manual handling for smaller first aiders. Other published methods of turning a casualty into the recovery position advocate holding the casualty's hand against their cheek and then reaching down for the leg with your spare hand to lift the knee. This places a strain on the back that can easily be avoided by switching the order around, lifting the knee first, using two hands if necessary, and then grasp the casualty's far hand, palm to palm, and bring it across and against the cheek. One point to note when teaching is to make sure that learners keep their hand on the knee after lifting it, because if a casualty is genuinely unconscious, the leg will slump back down if they let go. Finally, and very importantly, we've enhanced the advice that once a casualty has been placed into the recovery position, the first aider should continually monitor breathing until emergency help arrives. We included this update in response to a study that found that first aiders were a whopping 30% less likely to recognise that a casualty had stopped breathing whilst in the recovery position compared to the first aider monitoring the casualty whilst they were laid on their back. In the study, only 52% of first aiders recognised respiratory arrest with the casualty in the recovery position, compared to 82% recognition with the casualty on their back. People learn best by doing, so please ask your learners to demonstrate continually checking for breathing when they place somebody into the recovery position. This can be done as simply as feeling for breaths using the back of your hand. Make sure that they know to do this continually until emergency help arrives. Another key update to our First Aid Made Easy book is the inclusion of treatment for chemical attack, or as it's more commonly known, acid attack. Sadly, with these types of incidents becoming more common, first aiders want to know that they have the right skills and knowledge to effectively treat a casualty if they come across this. Containing step-by-step points, this section of the book will guide anyone through the best course of treatment to prevent a chemical attack situation from getting worse. In this section of the book, there's a subtle change in emphasis. We've renamed the topic of hemostatic dressings to wound packing. The reason for this is to emphasise that tightly packing a deep, life-threatening wound with any dressing is an important life-saving skill. Of course, if you have a hemostatic dressing available, that's even better. So it's a good idea to stock these if there's a high risk of injury. But any packing, even a sock, is better than nothing at all if that's all that you have. We've made some nice enhancements to the graphics in this section too. As you know, when a life-threatening bleed from a limb cannot be controlled by direct pressure, a tourniquet should be applied to stop the bleeding. I'm pleased to say that the guidance for where to place a tourniquet has been simplified in line with the new Faculty of Pre-Hospital Care advice. So what's changed? Well, the previous guidance advocated placing a tourniquet over a single bone, which meant that it had to be placed on the upper arm or the upper leg, even if the injury was much lower down than that. The latest guidance is based on military experience, showing that applying a tourniquet as close as possible to the wound is effective, even if the tourniquet is placed over two bones, so on the lower arm or the lower leg. And of course, this helps to preserve the maximum amount of salvageable tissue. So the new advice is to place the tourniquet directly to the skin just above the wound. The advice to avoid placing the tourniquet over the joint, so the knee or the elbow, still remains. So if the injury is directly below the knee, for example, then the tourniquet will have to be placed just above the knee at the bottom end of the femur. We've also increased the emphasis on improvising a tourniquet. We know that improvised tourniquets do work. Many lives have been saved using them, but there seems to still be a lack of awareness of this in the first aid industry. Learning how to improvise a tourniquet is arguably more important than learning how to use a manufactured one. You're very unlikely to have a manufactured tourniquet to hand when you most need it. We've also updated the treatment advice for burns, with the duration of cooling the burn changing from a minimum of 10 minutes to a full 20 minutes. This comes after porcine studies have shown statistically significant improvements in burn depth and skin regeneration when the burn was treated with cold running water for 20 minutes compared to durations of 5, 10 or 30 minutes. We were previously concerned that the cold water temperatures of UK tap water could cause a deleterious effect in the same way that applying ice is not recommended. However, the studies used water at a chilly temperature of just 2 degrees Celsius. Obviously, immediate cooling of a burn is best as it removes the heat, which prevents the burn depth worsening, improves skin regeneration and reduces scar tissue. There is evidence, however, that cooling for 20 minutes still has benefits, even if it's delayed by up to 3 hours compared to no cooling at all. So we've included this information in the books too. Finally, we've continued to emphasise the importance of not inducing hypothermia when cooling a burn. Cool the burn, but warm the rest of the casualty. I know that many of our customers will welcome this update as it still falls in line with the European First Aid Guidance, but now also brings it in line with advice from the British Burn Association. In the UK alone, sepsis kills 5 people every hour and kills around 52,000 people every year. However, if caught early enough, it can easily be treated. As such, for the first time, we've included sepsis in our First Aid Made Easy and Paediatric First Aid Made Easy books. Sepsis is a difficult topic to understand for clinicians, let alone first aiders, but we've provided an excellent description of the condition that's easy to understand, along with colour-coded tables that clearly explain the signs and symptoms of both meningitis and sepsis. While sepsis isn't currently on the syllabus for first aid at work training, I hope that you agree this is a worthwhile extra topic to include in the books. We will be producing a separate learning material for first aid trainers who want to improve their knowledge of sepsis. A small but important change to the guidance is that if you suspect that somebody is having a heart attack, bring the nearest AED to the scene as a precaution. Of all the conditions that a first aider may deal with, a heart attack is amongst the most likely to cause a cardiac arrest. So having an AED in the immediate vicinity is a wise precaution. Of course, we're not talking about applying the pads whilst the casualty is sat up and talking to you. The AED is there to be used if a casualty collapses. A word of caution, however, if a casualty presents with heart attack signs and symptoms and then becomes unconscious, this is most likely because the heart has stopped altogether. So it's time to quickly open the airway and check for normal breathing. If the casualty is unresponsive and not breathing normally, then CPR should be commenced along with use of the AED. These are some of the great new changes that we've made to our best-selling first aid books. If you would like more information or to purchase your copy of the First Aid Made Easy range of training books, simply visit qualsafe.com today.